First time I know the hemorrhoid embolization was a guest meeting in New York and around 2015, and so there was a session like Vanguard, embolization Vanguard. Vanguard means like something new, and at that time the session including me, MSK embolization and hemorrhoid embolization and also the bariatric embolization or something. So that was the first time for me, and we decided to start this technique from 2020. So we have 4 years experience, about more than 150 cases of hemorrhoid embolization. So let me introduce about the background and our treatment method and brief results. I think this is the first, not first report, but one of first report of 14 cases from Vincent, Professor Vincent Bedard from French group, and like this, and he is a pioneer of this procedure. And before his development, there was one physician, a Lucian physician, who have performed more than 100 cases of hemorrhoid embolization, is a right side person. And the left one is Professor Bedard, Vincent Bedard. And because I was also a pioneer of the embolization technique, so we were friendly, and I visited to Marseille. Marseille is in French, and he also visited to us. So that's the starting point for me. And as you know, the hemorrhoid is one standardized treatment option for hemorrhoid is a surgical treatment. But the goal of surgical treatment is not only the removing the prolapsing, but also the suture the artery. That's why the hemorrhoid surgery is very deep and invasive. And some physicians, there are lots of reported other alternative surgical technique like this, using scope and using color Doppler guided suture, like Doppler guided hemorrhoid artery irrigation from 2005. So the idea is that to reduce the arterial flow, inflow from the superior or middle rector like this. So this is a figure from the literature of this technique. They suture the wall and including artery like this. So the concept of the embolization technique is similar to this procedure. So we want to put a coil and stop or reduce the blood flow like suture, like this. So this is angiography, CT angio from superior rectal artery. You can notice that the arterial branch reach to the affected area, like this. So the affected area is not here, but here is this area, like the same as a pelvic synthesis. So the hemorrhoid is not disease of vein. So there is a physiological network and the artery and containing the artery and the vein. The function is this is a complex structure and the venous spaces, the small arterioles, and like this. So to increase the pressure of cushion. So, and the first symptom, there are 3 symptoms of hemorrhoid, as you know, the prolapse and the extrusion and the pain or discomfort and bleeding. And the embolization treatment is very effective for the bleeding and the pain or discomfort. The size of prolapse is also reduced sometimes, dramatically reduced, sometimes not change, sometimes it's not reliable. But the pain and the bleeding is, we can control well about the pain and bleeding. So the target patients, the good indication is the patients who have small or not suffer from the prolapse, but bleeding, suffer from bleeding or suffer from pain or discomfort. It's very important. So there is one breathing score from French group, Max Apoval, the frequency, breathing intensity, and the intensity of anemia, like this. So by using this scale, we can score the patient's intensity or frequency of breathing. And the cause of anemia is including the cancer, but also the hemorrhoid is a very big cause of anemia. And some patients have very low, very severe anemia. And the previous concept was the hemorrhoid is a vein disease, but now considered as a high arterial flow disease, like this. So corpus cavernosum recti, including the high blood flow in the patients with hemorrhoid. This is a figure of the high arterial flow theory. There is a grading scale of hemorrhoid. 0 is a normal, but 1 or 2, and 3 or 4 is having higher arterial flow. So it means, and also the resistance, the vascular resistance is very low. So it means that lots of effusion, maybe inducing lots of effusion. The tissue, chronic inflammation tissue containing the TNF-alpha, and the TNF-alpha cutting the surface of protein of vascular vessels, and the shedding such a protein makes the normal vasculature capillary into the microeffusion. So the high chronic repetitive disease, it's like MSK, like a jumper's knee or knee away, and frozen shoulder, and hemorrhoid, also containing the effusion. This is angiography from superior rectal artery, and we can see the brush and the high effusion, like a venous drainage is very higher. The evidence of early venous drainage. Sorry, this is also other patients. We can easily detect the artery venous shunt in the patients of hemorrhoid. So that means that we can access from the arterial side, not only the vein. Of course, there are some treatment for the sclerosing therapy to the vein, but we also can manage this disease pathology through the arterial side. And we use anoscope for the diagnosis or observation and educational for the patients. That is including the arterial blood flow or like this. So we use the anoscope like this, and I did lots of observation using like this, and explain the results to the patients, and patients can understand what is the abnormal vein vessels, not only vein but also the arterial flow. There's a movie of the anoscope. The left one, we can see the rectum, first rectum, and after that removing, and gradually, slowly removing, and we can see the vessel dilated, and like this bleeding point or the abnormal dilated vasculature. So the patient's relatively easy to understand that this is a disease of the vascular vessels. The right side is also the other patients. It's a normal color of rectum. During the cushion phase, we can see we can see the lots of dilated vessels and like brush-like vessels. containing the arterial blood, like this. So by using this, we can distinguish the patients of very chronic end-stage fibrillar pattern or the arterial inflamed pattern. So let me introduce our step or procedure for hemorrhoid embolization. We use a 3 French sheaths, a 3 French catheter, but the 4 French is also good, and 1.9 French microcatheter, and 16 microguide wire, and using a small coil. Hilar and tornado. We use a Hilar and tornado. So first, right groin puncture and select IMA by using a parent catheter. As you know, the IMA is origin from the anterior side of aorta at the level of third lumbar lateral body. And this is a good of the insertion of parent catheter. If you do not put the catheter in the right position, you will feel the difficulty to put the coil during the using a microguide wire. So this is also not good for so the stability of parent catheter is very important. And so ensure stability of parent catheter. And after that, performing full SRA, superior rectal artery angiography, and identify involved arteries. And this is one example of SRA angiography. And you can see the brush-like vessels, like this. So our target is here. Here is our target. So like this is other example of the SRA involvement. So we usually can usually find 4 branches from 2 and bilateral each 2, and totally 4 branch is normal, but sometimes patients have 5 or like this. So. And after that, we put the coil in French group. They put the coil here, like this, a very long coil from here and then here. But we don't do that. We will insert the microcatheter into the level of pelvic synthesis, and as near as this level, and put a small coil. That is our method. So after that, advanced microcatheter as close as possible to the pubic symphysis, and perform selective angiography to check for major anastomosis with middle rectal artery or other artery. I will introduce anatomy later, but there are lots of normal variant. So this is SRA, and we put the microcatheter into the end of close as the pubic like this. And perform angiography. We do perform angiography with pressure. We can see the anastomosis like this. So this is anastomosis from the left middle rectal artery. So we know that we have to treat the middle rectal artery like this. So because this anastomosis is relatively big. Some patients do not have a big anastomosis, a very small anastomosis. We can ignore the small anastomosis, but if the patients have big anastomosis, we will embolize them. Administer imipenem, small amount, to reduce the inflammation and the pain. So French group never do that, but but we do that too because we consider that hemorrhoid is one type of inflammation. So we use imipenem first and the coil replacement. So that can reduce the discomfort and the pain after procedure. So this is a figure during the putting coil, small coil Hilar, 2 millimeter Hilar, and 3 or 4 millimeter of tornade. It's very small. And after that, embolize involved arteries from SRA, all vessels, and for SRA follow-up angiography. This is a figure after three vessels embolized. And the left is a before embolization from the SRA. You can see the brush in the affected area. And the right side is after the embolization from superior rectal artery. So we can see this brush is not problem, but we don't see this level. So this is the endpoint from the SRA. And after finishing SRA, we do both internal iliac artery angiography and check the big anastomosis and embolize the major branch using coil. Not all branch, but basically the superior rectal and the middle rectal and the inferior rectal is connecting, but we always ignore the inferior rectal. And we sometimes the middle rectal is sometimes big, so we will put the coil from the middle rectal. So for example, that case, we have to check the left middle rectal. We put the coil like this. And we also put the right side coil. And if we put this all SRA and all both middle rectal, the ischemic event never happened. So the ignore IRA and there is some normal variant. This is a typical pattern: 4 branch from SRA and 2 branch from middle rectal. But some patients do not have this branch, for example, do not have this branch, and then alternatively arise from the right side internal iliac artery. So we call it SRA branch from internal iliac. This is one variant. The other is some patients have very small SRA, so which is do not reach to this level. So in this case, left or right side, there is some SRA branch from the left or right side like this. So we check the internal iliac. And or other patients have SRA from median sacral artery. So sometimes we check the median sacral artery. When we see the literature of the hemorrhoid embolization, nobody talk about the median sacral, but we notice that median sacral is also involved in some patients. So I will briefly introduce the literature or clinical results. This is the other group, 25 patients. Main symptom is bleeding or pain. And the stage is 2 or 3, not including 4, stage 4. And mean number of arteries is 4 or 4.2, but we usually embolize 5 or 6 arteries, but sometimes 4. And average coil number is around 8, or in our experience. Average procedure time is longer for us, so more, I think 60 minutes or about 1 hour, I think. And the complication, there's no pain, usually no pain. So of course there is evoked pain during the infusion of imipenem, but it's good. And after procedure, basically no pain. We didn't experience severe pain or severe ischemic complication. So it's very safe. It's very safe. And the clinical success rate is similar to this report. First responder is 85%. From our data, 85% first response. The bleeding reduced, or there's some patients have recurrence of especially the bleeding. So we do the second procedure in that cases. So this is last slide. So technically feasible, but requires. When I started this technique, we take 1.5 hours or 2 hours. Yeah, so now we can do less than 1 hour, but the starting point was technically feasible, but require technical demand. And the safety or no complication or lower complication, so we never see the ischemic event. If we use other material, we don't know, but we only use the imipenem and coil. It's very safe. And we do the outpatient 3 French catheter. I think that improves the clinical success. First is embolic material. Some physician using a particle, like a permanent microsphere around 700 or 900 or larger. Maybe it's good or not, I'm not sure. Or somebody use liquid embolic material, so we don't know. Thank you very much.